Okay, let's get started with the next session. We're going to move now to circuit dysfunction in human brain disorders. And our first speaker is Gilles Huberfeld from the Institute of Psychiatry and Neuroscience of Paris.
Thank you. Thanks a lot. Thanks to the organizers. I will try to tell you two different stories today that are connected, of course. And I will talk about how things may happen in the human brain and how this may encounter some specific neural behavior. And I will mostly talk about not directly epilepsy, but a very frequent condition from which we do have, all of us, a lot of different tissue, which is gliomas. And indeed, there are very strange interactions between the brain that hosts a glioma and the neurons in the microenvironment of those gliomas. And in fact, as in every drama, you need to consider it two different ways. First in time, second in space. So what happens in time? This is a typical case of a patient with a glioma. You've got here the MRIs a long time. Here you've got the volume of the tumor, which is charted a long time also. Here you've got a white line when he doesn't have any seizures. It's blue when he has seizures. And here you've got anti-seizure medications. What is really classical is that this patient had a first seizure with a specific volume of a left frontal lobe tumor. Then he underwent surgery, and after a period of few years, he, of course, didn't have any seizure. He was cured of the seizures. He could even stop his anti-seizure medication, but after a while, because those tumors do not cure, there was a progressive increase of the volume of the tumor. He had some seizures. He needed some new anti-seizure medication, and the tumor goes on growing progressively, and then he needs more aggressive treatment, and then the tumors become malignant, and so on and so on. But you see, there's really a parallel evolution of the seizure frequency, of the need to use anti-seizure medication, and on the dynamic of the tumor itself. And we know that indeed those tumors are very highly epileptogenic. Considering low-grade gliomas, about 80% of the patients have epilepsy at discovery, and this is going to increase progressively during the course of the disease. And if we consider glioblastomas, the ones that are malignant, the incidence is lower. It's about 30% at diagnosis, but it will progressively increase. What is also striking is that the rate of pharmacoresistance is progressively increasing, you can see it here, during the course of the disease. But what is perhaps even more amazing is that having epilepsy when you have a brain tumor will affect the prognosis, the survival. This is something we showed in a huge series of patients about 10 years ago with Johan Palu, who is the neurosurgeon I work quite a lot with. We showed that in a cohort of more than 1,500 patients with low-grade gliomas, when patients had seizures, they had a mean survival of 92 months. But when they didn't have any seizure, the mean survival was reduced to 50 months. That's really something striking. And it's also the case for glioblastomas, the malignant one. You can see here in this cohort of patients, single-center patients, that when they had seizure diagnosis, the survival was 15 months, and when they didn't, it was only 9 months. So there's an influence of the tumor on the brain, and there's an influence of the brain on the tumor. And maybe a nice way to image it is this way. A classical model for glioblastomas is to graft human glioblastoma cell lines into the brain of an animal. What is interesting is that once you do that in a mouse, for example, you can control the activity of principal cells or interneurons, and here it was done by an Italian group using optogenetics. And as you can see here, when you graft a tumor into the brain of a mouse in which principal cells activity is activated through optogenetics, you've got a huge increase of the tumor growth. If now you activate interneurons, you do the opposite, you very much reduce the growth of the tumor. And if you now try to move it to a more natural setting, grafting the tumor cells into the occipital cortex and exposing animals to normal light, light deprivation, light all time, you also modify the ability of the tumor to grow and to invade the surrounding brain. So they are really, really related. They come together. But there's also a specific area in which they interfere. This area is the peritumoral area. Here you've got an example, so it's an old paper from Huggins-Jackson's published 1882. What is really interesting is that during the surgery of a tumor that he wrote here, he said that in many cases epilepsy represents the initial symptom of the tumor. Okay. But he also stated something which is in fact amazing, because at that time he didn't have any tool to understand what was the area that drove epileptogenicity, but he said that epileptogenicity is related to the involvement of gray matter. So this is really amazing, and this is true. Another nice paper, 1966 in Paris. What is done here is a surgery in awake condition of a patient with a glioma that you can see here, and the patient was recorded with electrodes. You can see in one here that within the tumor there's no specific activity, and you can see that they could record interictal activities in the surrounding tissue, but not so far away. By the way, what they did, once again, it was published in 1966, is awake multi-unit activity recording in a patient. We don't do that so much nowadays. What is interesting, in fact, when we consider the interictal activity from those patients, is that it's really restricted to small areas that surround the tumor. Here it's a cortical recording with a grid, and you can see that interictal activity is only at the border of the tumor. You don't see the tumor, but believe me, but it's a small area. And a while ago now, we started to study those interictal activities, and more than that, in those peritoneal tissues, and we could identify that using the postoperative tissues, that if we did record in remote areas here, we didn't have anything. Away from the tumor itself, we didn't have any field events, but when we recorded peritoneal areas in here an interface chamber, we could record recurrent interictal-like activities, those field events, that were always recorded in the surrounding tissues, never in the tumor, never in remote areas. And for example, here, it's a patient with a tumor that you can see in blue, who was implanted with grid 3 weeks before surgery. The color code is the following. In green, there's no activity, no epileptic activity, but in red is the areas at which the seizures would be initiated. And as you can see in this patient, but in many others, seizures are not initiated into the tumor itself, but in peritumoral tissues. And when we studied at Paris those peritoneal tissues, we made an interesting observation, which was that, in fact, we didn't record interictal activities in areas that were within the tumor component if we considered macroscopically the tumor component, meaning the MRI, or even what the neurosurgeon identified as the borders, the limit of the tumor. But those interictal activities were rather recorded from outside of those macroscopic components, but we could identify a tumor cell infiltration in those areas of the slices in which we had those interictal activities, which means that perhaps they could serve as an electrophysical signature biomarker of tumor cells infiltration in areas from which the surgeon is blinded, in areas that in which we do not have any tool to identify the tumor cell infiltration. And indeed, this location is really important. This is a story, a paper was published 15 years ago now, but with very old data. At Saint-Anne Hospital in Paris, they used to do a lot of stereotactic biopsies. And what Johan Palu did is that he managed to get those biopsies. For some patients, they were MRIs. And what he did is that he quantified the amount of tumor cells with the location of the biopsy around the tumor. And as you can see, you can have tumor cells more than 2 centimeters apart from the macroscopic limits of the tumor. So this peritoneal area is really key. And you know that surgeons for those low-grade tumors, and as much as they can also for some glioblastomas, in fact, they have invented a new concept, which is the supratotal surgery. They know that there's a tumor, but they know there are some tumor cells outside of the limits. So they need to remove as much as possible cortical areas in order to remove those tumor cells they can see. And this is why we have so much tissue from tumor patients. And this is why this tissue is sometimes normal, sometimes not so much. And so this paraglioma tissue is indeed really important to identify, to assess, and to understand. Because in this tissue, what happens is the infiltration by tumor cells and then the efficacy of the resection, but it's also the area of epilepsy in those patients. And in fact, there's no real biomarker of both infiltration and epileptogenicity, especially during surgery. But perhaps there could be some biomarkers. And in fact, this might be the case of high-frequency oscillation and mostly fast ripples. We know in the epilepsy field that high-frequency oscillation are finally not so much specific of the epileptic area, but they are much more frequent in epileptic areas. And we know that they are also one of the key areas to be removed in order to be seizure-free after surgery. However, they might be difficult to record. And when we studied the postoperative tissues, in fact, there was a good correlation with high-frequency oscillations and tumor cell infiltration. So perhaps they can serve as biomarkers of infiltration. And in fact, using here macro electrode, you can see that we can record during surgery those high-frequency oscillations. We can record oscillations up to 600 hertz, which is quite a lot. However, they are not so easy to get, and we mostly use macro electrodes for that. For example, this is the Dixie electrode with a diameter of 5 millimeters. The spacing is about 1 centimeter, and they are thick electrodes about 1 millimeter. And what we know is that the signal-noise ratio with those macro electrodes is not so much interesting. And so we have been collaborating for a while now with a French company called Panaxium. And Panaxium developed, they're not the only one, but they developed a new kind of electrode, which is not based anymore on metals, but on a conductive polymer. Here it's P.PSS. And they can do very fancy electrodes. So the electrode is the following one. The diameter of each contact is 10 or 30 microns. The thickness is 4 to 10 microns. So it's very close to the cortex. What is interesting also is that the spacing is the one you wish. And, but what is even more striking is that with this technology, you can see here, is in the US a recording during a surgery. With this kind of electrode, in fact, the noise is very much removed. The signal-noise ratio is really, really interesting. And into what you used to be the noise, you've got those high-frequency oscillation, and you have multi-unit activity also, which is much easier to be recorded. And so based on that, we are developing a concept in which we record patients during surgery. From the cortical areas that would be removed, we quantify the tumor cell infiltration. And then we have developed this kind of concept of a mathematical microscope. We try to identify the electrophysical biomarkers that will better identify tumor cell infiltration. And this is done with Michel Le Van Cuyen. This is interesting. Of course, we are not the only group to do that. And there's a nice paper published a few years ago from the Stanford group. And what they did is that they recorded during surgery those patients. So it's a awake condition during glioma surgery. And what they could identify was that in what they call tumor contacts, which in fact are perhaps also peritoneal contacts, there are indeed okay, let's go. And indeed, what they okay. This is going to be the takeaway message. What was the number to remember? So, in fact, what they did is that they identified that there were more high gamma activities that you can see here in those cortical areas. What is interesting, of course, was then to study the postoperative tissues, and they identified that in areas with those high gamma, in fact, there was a higher connectivity, and then they could graft mice with those areas with high gamma and high connectivity versus lower connectivity. This had a key effect on tumor growth and on prognosis. And you can see here that mice that were grafted with highly connected contacts areas, of course, died much earlier. And what was interesting also was that this was associated with the upregulation of synaptogenic factor, here thrombospondin 1. And what is nice and interesting is that it seems that there's an anti-seizure medication which maybe is not the best one, which is gabapentin, which indeed is an antagonist of this pathway, and in animals it had effects. And a few years afterwards, it was validated in human patients that those that had gabapentin survived longer than the others in 2 different centers. However, when we do our recordings with the microelectrode in Paris, this is not really what we find. For example, here, it's a paper that was published last year. What we did is that during surgery, we used cortical macro, not the micro electrodes, and we analyzed based on the location of the tumor the rhythms. And in fact, we did the basal frequency and also the aperiodic components. And what we observed was that based on all those elements, and there are many of them if you consider all the frequencies, all the aperiodic and so on, that you can start to identify differences whether you are into the tumor, whether you are in the surrounding cortices, or if you are in healthy cortices. But in fact, we had the opportunity for about 36 biopsies to correlate directly the EEG pattern with real tumor cell infiltration. And what was nice was that we could identify something we call the normal behavior in healthy tissues, but then there was a correlation, a linear correlation for some of the features between the tumor cell infiltration and the disruption of normal rhythms. And based on that, we could even try to stratify and to identify differences between astrocytomas and oligodendrogliomas. And of course, we started to build a classifier, and this classifier allows to identify the tumoral part versus the peritoneal versus the healthy part, with for the moment not so amazing F1 scores, but we are progressively feeding the system and modifying it, and we are progressively increasing the quality of the recording. However, we were surprised because we didn't identify so many high-frequency oscillations. In this work, we use Ripple Lab, which is a software that was mostly developed by Michel Levan-Cuyan a few years ago. And using this software, we didn't have so much high-frequency oscillations. And this was a question. And indeed, in the literature, there are a few papers, not so much, in fact. For example, there's this paper that shows that there might be high-frequency oscillations. They are rather peritoneal, but however, high-frequency oscillations were considered as faster than 30 hertz, and the sampling rate was 500 hertz. Maybe not the best. In this other paper, we can see that it seems that there are more fast ripples in peritoneal and in tumoral and peritoneal contacts, however, and this is a bit amazing, the rate of ripples and fast ripples in post-reduction ECOG was not higher in patients with residual tumor tissue, not so much what is expected. and was higher in patients with good rather than bad seizure outcome, which is not exactly what is expected either. And to try to better understand the role of those high-frequency oscillations, we move back to postoperative tissue and slices. And what we did here is that in slices from peritoneal tissues with more or less infiltration, not so much in fact, what we did is what we know how to do. We have spontaneous interictal activity, we increase the excitability, and there's a progressive switch to a seizure. And what we did is that we studied the dynamics both in space and in time of those field events and of high-frequency oscillations. And field events, we considered two different events, the interictal activity, which are the spontaneous one, and the proictal discharges, which are elicited by this increase of excitation. And for high-frequency oscillations, we considered two different things. First, high-frequency activity, which is only the frequencies faster than 80 Hertz, and the high-frequency oscillations represent fast ripples, which was selected as oscillations and not only a frequency. In those patients, we had different seizure types. It's something we know pretty well, just hypersynchronous or with low voltage fast activity as initiation. The duration, of course, of the proictal period was variable, and so we had to normalize all the data. And what we found was that if we considered interictal activities, and if we consider the amplitude, duration, slope, and frequency, they were stable throughout the whole process of transition to the seizure. They were there, and they didn't change. If we now consider the proictal discharges, if you look at the amplitude, there's a first phase of increase here in blue, but then it's followed by a steady state, and after a while, there will be another increase of amplitude just before the seizure onset. So it seems that there's a 3 times period during this transition. If you look at the duration, it was the same, they increased and they were stable. And the rest was not so much different. So it's interesting because the slower component of this activity does kind of a plateau. If then you move to high frequency activities, it's no more the case. There's a regular increase throughout the whole process, you can see here, and even during the plateau, they would be increasing, and you can see the signature here, which is still evolving. If we consider now high-frequency oscillations, it's a little bit the same. There's a progressive increase in the frequency of those events, not the frequency within the HFO. We studied also the ripple versus fast ripple ratio. There was no difference, and we tried to identify whether the coupling between those high-frequency oscillations within the field event would change during the transition, and there was no difference. And then we moved to the spatial organization. Of course, so this is a sample on a slice. There was a progressive coverage of the slice. Back. And what was interesting was that during the whole transition, if we consider the initiating area and the last electrode at which we could record those events, it would be the same during the transition. But when we looked at the high-frequency oscillation, what was amazing was that they were organized in microdomains, so in restricted microdomains. And the main effect was that during the transition, there were more and more microdomains. So there's a progressive enrichment with HFO microdomains. And in fact, this is interesting because this might be a reason why with our macro electrodes, perhaps we didn't get so much of those micro domain limited high-frequency oscillations. And we are now building kind of a whole system with recordings during surgery, with imaging of the data, and enrichment of the surgical theater with those electrophysical data. A reason why perhaps we didn't identify them so much, and I'm close to the end, we know that, in fact, there are not so many papers that show this dynamic of HFOs during the transition to seizures. Here, there's a paper on human that shows that they increase during the proictal versus the interictal period, but not in all patients. Perhaps using this could be useful for seizure forecasting, but it's still not so much the case. And this might be interesting for seizure forecasting. However, it might be also a question of tools, And we recently in the lab, we in fact, is Sylvia Casas-Cuniera. She developed a very, very nice tool that you can download, which is called SpikeSpectre, which is a tool that was done by using MEA, study all the, for the moment, field events that you can record, and merge the data with the imaging data. And she really did it well. And in the next iteration, there will be the high-frequency oscillation, and then there will be the multi-unit activity, but it's still not done. And something else also, a new tool we are using in vivo is a software by a company called Avrio. The name of the software is Alicia. And honestly, it really helps detecting intracranially inpatient high-frequency oscillations. Thank you very much. And I really want to thank Elena, who is co-leading the team with me now, and the two surgeons from which we have so many of those tissues, Laurent Capel, who passed away 2 years ago now, and Joanne Palu at Saint-Anne Hospital. Thank you.
Thank you for a terrific talk. We have time for a couple questions. There's actually one behind you.
Thank you so much. This is really fascinating work, and I think it's cool to see that glioma is working and is going into the space of like a network perspective on it. So my question on the neuro-oncology paper that you talked about, did the patients, like, what was the anesthesia used? Was this awake?
Awake. Everything is done awake. Yeah.
And is the protocol in your institution that they first go into anesthesia and then are they reawake?
Yeah.
And is that could that maybe also affect the frequency of high frequency oscillations if they are still like a little hungover, let's say?
So for those recording, I cannot tell you because we didn't do it this way. Now what we do is that we start recording once just before they stop the anesthesia. We're interested into the transition. But indeed, all those patients, so the anesthetics that are used are very short half-life anesthetics. There might be a few differences, but anyway, all those recordings were really done in awake condition during the phases during which the surgeon is testing the different functions and so on and so on. So we don't have any interference with the anesthesia here.
And I think if I remember correctly, you saw an increase in delta activity in that paper. Is that correct?
In the tumor.
In the tumor, but not in the peritumoral. Okay, thank you.
Yeah, which was expected, in fact.
Yeah.
Hi, really, really interesting. I guess the question I would ask would be, do all of the patients that are undergoing surgery have the same anti-seizure medication profile, or are they all receiving different medications? And is there a correlation with the type of anti-seizure medication they're receiving with the type of high-frequency activity you observe?
So this used to be an old question when we started to use postoperative tissue, whatever the condition was. We tried and failed to identify a difference based on the anti-seizure medication, many others also. For the tumors, there's something which is a bit specific, is that the patient pathway is mostly, at least in France, in most cases, these patients are managed at the very beginning by surgeons, and surgeons know only one anti-seizure medication, which is levetiracetam.
Hi, thank you. Terrific talk. I was wondering, do you have a notion, or is there a notion of how the tumor cells affect the surrounding network? Like, it looks like there's an overall disinhibitory effect, but this could be due to selective loss of interneurons or differences in ion homeostasis. I'm thinking of chloride mostly. Is there like a general idea here already, or some hints?
So we didn't do it yet at the good level of resolution in order to identify very precisely the interactions with a group of tumor cells with the surrounding neurons. We know that there are modifications, there are less PV cells, but there are a bit more synapses. We know, of course, that there are chloride modification and so on and so on, many of those. And this is one of the reasons why also we developed this SpikeSpectre tool, because it really allows a nice correlation within tissues with the histology. And in fact, we are going further now because we try to start to record with higher resolution electrodes. So now we use the 3-brain with about 4,000 electrodes. We then do histology, but we also now do a spatial transcriptomic with more or less the same spatial resolution. And we are starting to try to do metabolomic also with a resolution which is not so much different. So then this is typically the type of response we could give you, but I'm not sure yet.
Thank you.
Okay, I think we need to move on. Thank you again.
Thank you very much.